here, a retired psychiatrist. Be glad to support or counsel our members. Is there something formal set up on that? We can talk that. And then the suicide of Dr. Breen, that there were no clues until the very end. So, all right, some important topics and some big topics. And I think before we get to the those end spectrums, let's sort of back up and think about the environment and the individuals. Particularly, this is about physicians in the COVID era. And, to think about how, one, rapidly this occurred, how two, underprepared we were. And when I say underprepared, I'm not talking just about PPE. I'm talking about, from a psychological resilience standpoint, physicians have not, at least in, our generation, been trained as warriors. There has not been sort of the sense of having to quickly sort of deploy and go into battle. So there was a lot asked upon our community very quickly with a lot of uncertainty and also a lot of, sort of lack of training. I think while our medical skills, are obviously outstanding, and we have some of the most talented physicians in the world in this country and here in DC, one has to think about for a profession that was already struggling with changes in technology, legislation that wasn't keeping up with times, or technology that wasn't keeping up with legislation, EHRs, telemedicine. I think one of the few positives of this event has been some rapid changes in the way we do things that may not have happened had we not been pushed to the fire. But when I talk with colleagues about this topic, the thing is what are in our medical school curriculums? What are in our residency curriculums? What is in our faculty development? What is in our continuing medical development to help us deal with uncertainty, to help us deal with the unknown, to help us deal with things that are rapidly changing that are outside our control? Now, of course, part of medicine is just that skill. But what we know, doctors tend to be obsessive compulsive. They tend to be very perfectionistic. They tend to have exaggerated senses of responsibility. And I'm not, by saying that, that's not necessarily a bad thing, but it can get us into a very challenging place where we as an individual feel that the world is upon our shoulders and that we have to have an answer. And so something like this, where there aren't answers, there aren't clear-cut pathways, protocols, things are changing by the moment. I'm not quite sure medicine sets us up in a systems approach to deal with this tremendously well. Now, of course, I would say most physicians have risen to the occasion. We have seen remarkable things happen. But then, of course, at what cost? And I think the suicide of Dr. Breen is a great example of, what is the collateral damage that is the potential of occurring here by having, people thrown into the fire who may not necessarily have been prepared, or who necessarily have the systematic structure or support to deal with it. So that's sort of the context that I lay this out in. And, as we think about, promoting well-being and promoting a sense of wellness, for lack of better words, I think it's really critical that we think at a systems level. And, today I'm going to ask more questions than I'm necessarily going to provide answers, which may be frustrating. But I also think that, I want to hear from some of you on here about things that you've thought of, some things that maybe you've seen that have worked, that haven't worked, or et cetera. And so, the big things, and I'm going to put these into the chat box. I didn't decide not to have a slide, but, the research literature, this comes from the business world, and it's been translated over into medicine. It's been around for decades. But if we look at things that potentially lead to burnout in physicians and, problems, so the first one is, hold on, let me make this go to everyone. Work overload. All right, so that's definitely something. I'm going to list these out and then we'll go into details. Lack of control. This is another one that we know is a big risk factor. Insufficient reward, and this is where I commend our mayor and some of the folks in the media who have really looked at ways, to reward and make healthcare providers feel like heroes as a way to keep morale and keep, folks on the front lines feeling good about what they're doing. Unfairness. Okay, this is another one. Breakdown of community. And then the final one is value conflict. And some of you may have heard this term moral injury. That sort of plays into it, where I feel that my hospital values making money, but I value saving lives. And so it becomes a moral injury to me when I am forced or feel handcuffed by billing and coding decisions, as opposed to perhaps some of the reasons that brought me into medicine. So I think the other ones are pretty self-explanatory, but value conflict is around that issue. And so as we think of this COVID situation, work overload, I think that goes without saying for some. Now, it's interesting. I have a friend who's an orthopedic surgeon up in Boston, and he said he doesn't know what to do with himself. He said he's not used to ever in his life. He has never had a time where he just has nothing to do. I don't want to assume for everybody it's work overload, but certainly there's been a change in the way we're doing things. And even for those who may not be on the front lines, just having to switch over to new technology, new systems, new ways of doing things. We've all been challenged with a lot of new things. It's been a tsunami of new stuff thrown our way in a very short period of time. Lack of control goes without saying. A pandemic, that it is lack of control. And particularly when we see folks in the federal government, many who aren't scientists, calling some of the shots, or even local government, it can be very, very challenging to think about our role as a physician scientist in the midst of, regulations, rules, laws. I heard someone talking about the social distancing, even with stay-at-home orders on a beautiful day. There's no control. You're going to, if you want to go out for a walk, it's going to be you and your favorite 3,000 friends on that pathway. Insufficient reward in terms of, if there isn't monetary reward, how are we rewarding each other? And we're going to talk more about some small things that we can do. Unfairness has been huge. We had a huge debacle at GW about, psychiatry, we don't need to examine a patient, in terms of putting our hands on them. So we wanted to do telehealth. Well, then it became, then can geriatrics do it? Well, then what about endocrinology? Well, what about dermatology? And so then it came into this huge question of, if you get to use the camera, who else gets to use the camera? And, and then what about the nurses? Are the doctors just leaving the nurses out there, hung out there to dry? Has this become a pandemic of where nurses get exposed and doctors sort of hide behind cameras and phones? So fairness has become a huge issue. Community. This is an area where I think, again, we've seen some rallying. We've seen people come together. We have, I think in the Washington, D.C. area, and you just look at the way medical societies have gone in the last decades, the community has started to pull apart. And, how can we view our colleagues not as someone who's dumping more work on us or calling a bogus consult, but someone who's actually a friend, someone who's actually on our side, someone who's there to help us. And then, of course, the value conflict that I talked about. So what you'll notice there is a lot of these wellness initiatives focus on things like yoga and wellness and mindfulness. And I have nothing against those. But when I think about, the things that challenge us, I'm thinking on a much more macro level of what do we need to do and put systems in place to help individuals feel part of a community, feel rewarded, feel that their values are in alignment with everyone around them, feel like it's a fair game. To me, those are the answers to how to promote wellness. And certainly exercise, breathing, all those things are diet, sleep are critically important. But I think sometimes our wellness initiatives get a little bit tangential to the big issues. When we say, oh, we'll just go do some yoga or just do some breathing exercises or go meditate. Meditation is helpful in the minute, but in the big picture, we got to think about some things. So here's a few things that, have come up on my radar, and then I'm going to turn it over to you. In terms of work overload, one of the most fascinating interviews I saw during all this was by one of the astronauts on the International Space Station. And you're thinking, well, what the hell does that have to do with anything? Well, what that has to do with anything is this guy, of course, was quarantined or isolated for a year in space, i.e. could not go anywhere. And some of the tips and pearls he said made a lot of sense to me, which is number one, our inclination when things change dramatically is to like do, and everything has to get done immediately. Some of you may have felt that way about some of your spring cleaning. I heard the garbage men in DC have been overwhelmed by the amount of stuff that has been thrown out because people are like going nuts, cleaning and throwing things away. And one of the strategies is, how can we break things into smaller chunks? We don't have to, Rome wasn't built in a day. When we're faced with this, when things start to speed up, how can we slow down a little bit? And how can we start to prioritize and put into place ways so that, we don't have to get everything done immediately? Think of this as a marathon, not as a sprint. The other thing that he said was how to, when you're isolated and don't have some of the social supports, don't have the distractions from work, what are ways to keep your mind away from anxiety, away from fear, away from negative thoughts. And it was, something very basic, but hobbies. How can you, in your downtime, find something that you really have had a passion, maybe something you did in college or that you lost, in your medical career. I hear a lot of doctors, this whole thing about physician suicide. When we talk to doctors who are depressed, burned out, disruptive, they always talk about loss. I used to be a painter, but then, medicine just robbed me of that. Or I used to love to play football or sports. Probably not the best hobby to pick up right now, a team sport. But the point is that a lot of physicians have, when you delve into their narrative history, and these are the ones that get into trouble. So I can't say it applies to this group. I'm assuming this is a wonderful, high-functioning group of physicians I'm talking to. But the point is, I hear a lot of loss of things that were part of childhood, college years, even into medical school, that somehow, because of the demands of adult life and medicine, sort of took away. And so how can we reconnect with that? So those are some little pearls that I thought were nice. Reward. I'm going to jump down to that one. Control, I'm not big on control. I mean, control, we can control what we can control, and there's other things that we just got to accept we can't control. And at some point, part of wellness is letting things go. But reward becomes really important, and this gets down to this nature of positive psychology. How often have you walked into the hospital and told someone or your clinic what a great job they're doing, or how thankful or how grateful you are for them to be there? I've heard a lot of strategies of people trying to start rounds with like gratefulness rounds, taking 5 minutes at the beginning of the day to just say how grateful they are that someone did something or that something happened, or talk about something good. But trying to, in this world of negative news and just, the headlines that are horrific, how can we start to reward each other by cognitively reframing the conversation into things that people are doing well, what's good, what we're thankful for, and why we're appreciative. And of course, that then helps with community, feeling connected to people in the community. One of the things we've done at GW is we've started a community happy hour. So we have the medical school. We had one of the deans play the trumpet. So again, getting him to connect into one of his hobbies. He did a trumpet concert for the faculty and for the students. We had a cooking class. One of the professors did a makeup and hair session. And so we've tried to bring each other together in this way by not teaching more biochemistry or anatomy or doing COVID protocols, but just bringing people together. And of course, completely voluntarily. We don't, we're not into demand, we don't want to cause more work overload by making a wellness activity mandatory. But for those who want to connect and be part of the community, to really to find a way to come together. So, I think these, what we talk about are these sort of three different levels. Level one is sort of the individual practice of, mindfulness, yoga, breathing, exercise. Level two starts to then get to these broader things about how can we think to putting things in a systematic way to help combat some of the well-known evidence, towards physician burnout. Level three then gets at Dr. Breen and the suicide and the physicians who are really struggling, which luckily to date, we don't have evidence that Dr. Breen is the exception, not necessarily the rule. Right now, but again, we don't know. We don't have the data. No one's really asking questions. And what I think is so astute about this comment is that, with physician suicide, what we often see, and with most suicides, is you don't know these things. It comes out of the blue. You can always play, Monday morning quarterback and go back and be like, oh yeah, there were signs. But going prospectively forward, oftentimes you don't see them. They're very hard to see. They're not out there. And so I think the level three thing becomes, what can we do to identify physicians or any healthcare provider who is struggling or having a difficult time? Or more importantly, how can we ensure that the resources that we have get to those folks? We right now are bombarded with resources. I mean, the emails, it's just crazy. And so the thing is I'm actually not worried about resources. What I'm worried about is how do you navigate this sea of all this information coming to us and getting the right people to the right resource. And that's where I think we're missing the boat. The people who are in the hospital, working hard hours aren't really necessarily the time to weed through all these emails to be like, okay, am I a mid-level nurse in distress? Okay, well, there's this physician health program. No, that's physicians. Well, then there's this nursing program, but no, I'm a nurse practitioner. Like, getting people to the right place seems to be a complete mess right now. And I think in the coming weeks, that's the thing we really got to work on, is how can we get to our frontline providers or any providers, one, the message, we care about you. Two, we're here. But three, how can we get you to our services? And this is no different than any time. Steve Carreras, who's on the call, who is our, case manager and so much more for the physician health program. We struggle with getting people to access the physician health program. There's stigma around mental health. Being a physician, it's seen that if I have emotional problems or I am depressed or I'm overwhelmed, then that equals weakness. And of course, weakness in medicine is something that we don't tolerate. It's something that was pimped out of us in our rounds when we were, in medical school. And the worst thing you could be called is weak. And so stigma plus this environmental cultural component of medicine puts a lot of barriers so that folks like Dr. Breen are going to be very unlikely to reach out. So it is the onus upon us to reach out to them. Of course, we don't want to be like an interventionist running around the hospital like, hey, are you okay? That could be very intrusive. So it's a tight balance of how do we get the word out? How do we help people really, know what the resources are and get those people to the resources? So that's all that I have prepared to say. And so that's taken us up to about half our time. And I'm now open to wanting to have a dialogue of what resonated with you. Maybe where did I miss the mark? What's on your mind? And let's get into a dialogue about how we can address, provider wellness and burnout during these challenging times. So, Dr. Dyer says we need to consider that Dr. Breen might have had cerebral injury from her COVID-19 infection leading to her suicide. Certainly, certainly possible. Again, one of the things we know about doctors is they are terrible about you know, taking care of their own health, you know, and doctors will come into work ill rather than take a sick day. So, you know, the question, of course, is what follow-up was done, how much guilt and shame was there? And this is all speculation. You know, we have the Goldwater rule about public figures, but Dr. Breen is, you know, I've never met her, never evaluated her, so I'm not going to make any diagnostic kind of statements, but simply say in general, we know that physicians are terrible patients. And so, you know, the question is, what kind of reentry was there to ensure that that individual was safe and ready to practice? Don't feel you have to just type. You can also speak in.
So this weekend, the American Psychiatric Association was supposed to be meeting in Philadelphia, and the meeting was canceled, but they had 2 days of online seminars.
Yeah.
Couple of things. One is the progress that's been made in telepsychiatry and telemedicine during this crisis is that, CMS has dropped a lot of the regulations. People can treat people. In psychiatry, you had to be in the state where your license was and see people in your state. Now it's kind of opened up. You can see people in other states. Telepsych-wise. And also the coding and the billing and everything has gotten better. And the prescribing is getting better too, which is good. And I know I have colleagues that are not psychiatrists in private practice, internal medicine, ophthalmology, who are kind of conducting telemedicine. They're screening their patients and using that to see who really needs to be seen and who doesn't. So, you know, I think that's a big change in medicine, and I hope it continues.
I would certainly agree. Certainly agree. I think that we have done, you know, some remarkable things in that regard.
Yeah.
And one of my questions then becomes, I mean, one of the things we were thinking about is, well, how could we extend that then to our own? So if someone was, you know, an emergency medicine doctor was struggling in the emergency room, would there be a way to zoom in? And could someone like, you know, Steve Carreras or some, you know, there's physician hotlines, but be there to support someone in the moment who needed some help? And, you know, so I think these telecommunication things are not just good for our patients, but they might be good for us as a physician community.
Right.
Other folks or questions or comments?
Well, I would, based on my practice, I was a pathologist for 35 years, and I was on a medical executive committee in community hospital for 20 plus years. And I think the problem we had virtually with every monthly meeting was some member of the medical staff who treated others poorly. It seems, I think physicians can tolerate a lot regarding poor outcomes or workload, but if they're getting criticized on a daily basis by somebody who's got some kind of narcissistic disorder, and the national meetings I went to indicated there's somebody in every hospital that's a chronic problem, that treats their colleagues poorly, treats the hospital staff poorly. And unless the executive committee functions in the way they're supposed to, and this is an accreditation issue, because if a nurse calls up a physician at night and gets yelled at, she's not going to want to call anymore. And so that affects the quality of care at that institution. But unless the chief of the medical staff and the executive committee functions and enforces hospital bylaws, then not much is happening. So I think that can degrade morale and a mood of physicians, particularly that if they're under stress otherwise.
Absolutely. I mean, this problem of, you know, what's been called the disruptive physician or the distressed physician, you know, has haunted medicine for a long time. And what you cite is a well-known theory called, one bad apple can spoil the orchard. And in fact, all of us probably from our medical training could tell you that one person, often a high-powered interventionalist or surgeon or surgical subspecialist, who was incredibly demanding, belittling, and quite frankly hostile or abusive. And what's interesting is, so one strategy is, you're absolutely right, is how do we excise those people from the medical environment? After, obviously, with due process and with the recognition that some of this is skills-based. So some of these folks, they're just not going to change. It's ingrained in their personality. But actually, for some of them, there are skills, communication skills, anger management skills, ways that they can be taught to act better. And oftentimes the problem is it becomes this, it's tolerated until one day it's not. And it doesn't give the person ever the real chance, or they're told, you just need to stop doing that. But they're not given any kind of skills or remediation on how to actually do that. If it were that easy, they'd push a button and stop it. So there's that group. But then even if you excise that person, and I agree, good codes of conduct, bylaws, functioning executive committees, that, again, this comes down to values, which is oftentimes these folks are high money earners, they're VIPs, sometimes they're even chairman of the department. And so it comes down to, well, what do we value here? Someone who's, do we put up with this because they're, bringing in so much money, et cetera. But you're right, the safety risks are tremendous. But even if we were to excise that person, we still have a morale problem in medicine, where we have a culture that is not very nice, where we're not very nice to each other. We're nice to each other oftentimes in silos, sometimes, but, dissing specialties, the number of other services that have told patients that psychiatry is worthless, or why would you want to consult psychiatry, or they're no help. So, we diss each other. We don't respect each other. Nurses yell at students, attendings yell at nurses. So we have a more rampant problem of community that I think is, not just a matter of getting rid of some of these bad actors, but how do we focus on instilling and fostering behaviors that promote, cohesiveness and community. And I think a lot of this, the research literature comes back to some of these burnout factors, which is, some of the things that are stressing individuals also stress the system at large. So, that's my take on it from the physician health standpoint, but I'd be curious if others have a thought, because I think the nice thing right now is people, I think when this COVID thing broke out, there was a lot of, conflict and like craziness, but then people kind of rallied. And right now there is more of a collegial sense, at least I've seen in the hospital and departments, than I've seen in medicine for a long time. And I'm worried that that's going to go away. As we start to get out of crisis mode, we're going to just revert back to this kind of cantankerous culture that we live in, and that would be a shame. But thoughts, again, we have a lot of experienced and expert people on here, so I'm curious to what you got to say.
There are programs, and we availed ourselves, at least one, where they're in residence programs. We had one surgeon who we said, if you want to renew your privileges, you have to go there. And they did. And I think it wasn't easy. I mean, it was pretty much like going to Paris Island, where he was getting some of the medicine that he'd been dishing out for decades.
All right. Was it effective? Did he come back changed, or was it not effective?
I think to an extent, it was helpful.
Yeah. Yeah, no, there's a variety of different interventions, everything from coaching to CME to residential for physicians who have trouble. But again, they're oftentimes costly. There's waiting lists. There's lots of barriers. And so again, it speaks to, a resource issue.
There wasn't just physicians at this place. I mean, it was in Atlanta. I mean, there was there was Delta airline pilots there. They were there for the same reason.
Yeah. So I know Talbot's down in Atlanta, but there's a few others down there. So I got a question that comes in. How does a doctor know whether the stress they feel is normal or dangerous? What is normal in this era? So that's been a question that, of course, I think any of the psychiatrists kind of would resonate that, I think if anyone weren't somewhat anxious right now, you'd think they were diagnosable. I mean, some general level of anxiety is very normal given the circumstances and the nature of this disease, the COVID, and what's going on in our environment. And I think one of the things is, again, normalizing that. And that's another area. Physicians are not very good about talking about their feelings. Physicians are very good from here up. We have great medical knowledge. We are able to talk about protocols and pathways and drugs and bugs, but we're not good from talking from down here. About feelings. And so to normalize that, that's one of these, wellness things that I've seen are these huddle rounds where people check in and just, do a feelings check. How are you doing today? And normalizing, yeah, you're scared. Yeah, we're all scared. But that's something that I think could be institutionalized, not just now, but down the road. I heard an example from a medical student once at another institution who, told me a wonderful story. We were asking the question, name a resident or tell us about a resident who did something really well. And the student said, it was awesome. At the beginning of each day, the resident would say, let's talk about yesterday. We want to talk about one thing we did well and one thing that maybe didn't go so well and what we learned from that. And certainly I can't think across my medical education of anyone who ever did that with me. If we ever didn't do something well, it was either not talked about or it was covered up. And so having vulnerability or expressing that it's okay to not do well or to maybe not have achieved what we wanted to achieve or to be scared or to be anxious, that's just not ingrained in our culture. And, I think it's something that we really need to think about as we go through this and look at some of these teams that are doing these activities and seeing, what the outcomes are from that in terms of, not necessarily patient outcomes, but outcomes on the morale and mental health of those who are involved. But, other thoughts about, sort of what's normal and what's not normal?
Well, I'm not on the front lines. I don't know what those people are going through. I can't imagine. But I think for the most part, the only way they can be getting through this is supporting each other, the nurses, the doctors, everybody working there. There has to be some kind of support system because they're not getting it from outside or anywhere else. So I think that's great. One thing I think that might be helpful is like to MedChi, the Maryland Medical Society, puts on the bottom of their newsletter that about, help for physicians, especially during the COVID crisis. I think we could do something like that for the DC, and put it at the top and say, this is available. If you doctors or healthcare people are going through some hard times, please reach out to us. These programs are available. There's help available. And maybe so people see that it's easier to get help than they would think of.
Pia, do you want to chime in about sort of what MSDC has been doing in terms of outreach and advertisement?
And we had actually been offering counseling services. We had partnered with a couple of coaches, and it's gone out. But if I hear you, it's not very obvious where it's located in our newsletter, and if we put it up higher, then you might not have to dig down. I think that's a very good suggestion, well taken, and we can incorporate that into our newsletter. Thank you.
Yeah, that would be good.
Yeah, it's great.
This is Desiree Pineda. Can I say something?
Please.
How you doing? So our website is actually has, if you see on the top, when you go to the MSDC website, on the top it says click here for COVID-19 issues. So there is a well-being page for just for COVID-19, and there's a lot of things there, not only about well-being, but how to manage your practice during COVID-19, how to get other things, new newsletters, things are happening in the government in DC. So it's kept really up to date, and the staff is doing a wonderful job doing that and keeping it really up to date. From the well-being program, we have 2 coaches that they have really given their time to anyone that wants to call them for a 45 minutes session. And they're doing it not only once, but they have done it 2 or 3 times for the same doctors. So it's working very well. We have had very good feedback, and we're very happy that they're being able to do that. And Dr. Samenow and Dr. May, they all have also suggested and help us. And if anyone wants to talk about anything, or they have a question or something, they also are free to talk to them. So we are very grateful to them. We can certainly make the well-being part a little bit more. People can see it a little bit more, but it's really being utilized right now. So
It's good to know.
yeah.
There's so much COVID information coming out. You don't know where to go or which website. So like I said, if we reiterate, we're especially about wellness and stuff in light of we know that people are suffering, and obviously somebody suicided about it, that maybe that we need to make that more obvious that we're here to help and stuff. So,
Yes, so I welcome you to look at the website, and any suggestions, please do.
I usually don't go to websites. I have enough emails to go through every day that websites is not the first place I go. So that the emails would be helpful, and stuff for the newsletters. Yeah.
So, I think that's one of the things is that, there are a ton of resources out here, and Dr. Pineda and the MSDC has set up this wonderful, coaching program, and the MSDC Physician Health Program has made themselves available, but we just aren't seeing the people yet that much. And so, part of it comes back to what I said at the beginning, which is, I think the resources are there. I think the challenge is how to effectively get those resources to the people. And because you're right, websites you've got to go to. And most people are not going to be hunting around like for MSDC website. Maybe they will, maybe they won't. Number 2, emails, it's just like killer, the number of emails that are coming in. So someone says, I wonder if a personal connection. And I think that's right. I think we got to get stuff on the ground. I think, when I was at Vanderbilt, which has been a real champion of physician health, they used to have the physician employee health program as the badge holder. So the little thing that you would pull the badge, it would have the number for a specific physician helpline. And, it was given out to every resident, every new employee, every physician had it right there on their badge. This is the number you call for physician help. And so, I think we got to think about innovative ways to get the resources in a digestible way and a way that will help, connect people to things that already exist. I think developing more is not the answer right now. Other thoughts?
Yeah, I have a question. Can you hear me?
Yes.
Yeah, it's Judith Novak. I'm just curious, have there been hospital systems in the area that have been more overstressed than others that might require more attention? I assume we haven't actually thankfully been, in a sense, attacked the way New York was. Do you know anything about that, or does Julia?
I personally don't know. I'm at the VA and at GW, but those are the only 2 that I've seen, but I don't know.
Okay.
I think if you're talking about just infection from the infection point of view, I think they're equally, there's a lot of, as you know, in Ward 7, Ward 8,
Right.
the majority of the patients that they are infected. So, and we only have one hospital in that area. So it is, so it's being bombarded, that area is being bombarded with this. But other than, you know, the MedStart and GW General, they are just, I think they're more or less equally. We don't get numbers from each hospital, but we do get about how many people are hospitalized and how many ventilators we have available. And so far we're doing pretty good. So it's good.
Good. One of the things is the governor of Virginia just announced that they're opening up the hospitals for non-emergency patients starting on, I think, Thursday night or Friday. Any idea as to when that might happen here in the district?
I can answer that. We don't have any idea. It's right now the DC Health and the mayor has a plan, and he has with they're working with Johns Hopkins to see all the steps that they need to go through to open the city. And that's what I can see also in Ohio. That's exactly what they're doing first. So that's the first step that all the states are taking. We don't know exactly when, but I think it's coming soon, because they said about the deadline, it was going to be May 14th to open the city. So they have to start saying all those things now.
Okay.
They usually give a brief, you know, every day, and we are, you know, we look at it every day, but they haven't given dates itself, but they're already working and they have a plan to open DC.
One other thing, because I don't know, I'm not sure anyone would know for sure, but I was wondering, have any doctors, nurses, or other helpers in any of the hospitals in this area gotten COVID and died from it?
I haven't heard of anything.
No, we haven't heard of any of them, and we probably will hear, but we haven't heard of any positive ones even, or anyone that has died from it.
Okay, thankfully, good.
The other problem is that we are not being tested, you know. So GW does have a test for the healthcare workers, and MedStart also, but in general, you know, we are pushing for that. That's one of the things that we really do in advocacy, to be sure that doctors are being tested, or healthcare workers, nurses, nurse practitioners, because the lack of testing, we have not been tested. And even if you're positive, they basically tell you have to go back to work.
What? If you're positive, who tells you that we have to go back to work?
The hospitals. They tell the nurses too. Mm-hmm. So we've been fighting for all
There's
that.
been some trouble, a lot of trouble around that. Sounds like Dr. Pineda is more up to date than I am, but there has been a lot of pressure or thoughts of folks that, you know, again, healthcare workers are getting a very different message than what the general public gets. Did we lose you, Dr. Nowak, or any other?
No, I'm still here.
Just digesting.
I don't know what happened. It was like, I don't know. Anyway. What expected to go back to work, with any provisions for any kind of safety, or just go back to work? Because I haven't seen anything about that.
Well, there's nothing written. That's the problem. So basically, if you're okay, I mean, if you're physically able to go back to work, you just have to put your PPE on and continue working.
Wow. Okay.
So we and MSDC are fighting very hard for that, and to be sure, also we have a statement out to be sure that doctors and any healthcare worker can say what they want to say without being retributed or have any problems in their jobs about it.
Okay.
And with all the presence of the Medical Society through the Mid-Atlantic, which included Virginia, Pennsylvania, we have put together also a newsletter saying that we doctors should not be punished for saying what they want to say.
Right.
Which is that's part of your well-being. I mean, you really want to you want to express what you feel.
Absolutely.
And again, that, I put those factors up there for a reason, because in, years and years of doing physician health stuff, it's the one thing that really I keep coming back to and thinking about when we are trying to intervene or do wellness strategies, like where should we be targeting, and that value conflict keeps coming up. So again, if someone's saying silencing a physician, or a physician's not able to say what they want to say, it puts them at direct conflict of the system or the governing body or whoever they're working for. And, it leads to moral injury. It leads to burnout. It leads to not good things. And so, the MSDC really speaking up for physicians having that freedom of speech, it falls right into an incredibly important domain of how to promote, physician health.
Going forward, I mean, not for right now, but this is something that it's one of my own interests. I've gotten very involved in something called the patient safety movement. David Mayer, do any of you know him at all? Dave was the executive vice president of patient safety at MedStar, and now he's leading a foundation. And he operationalized a method whereby hospitals can get a grant to implement a project called the Candor Project. And basically it involves, 2 seconds, and then I'll say how it might relate to this in a positive way, is the idea is that any adverse patient event is reported, and that 3 teams basically are sent out, one to support the family, one to support the doctors and nurses and staff, and the other to investigate the medical record. And one of the things that I see as potentially positive about this is that it's not a blame system. It looks more at supporting everyone in the system. And I would think that programs like this that basically promote honesty about making mistakes. Part of the program is that if it's decided that it was malpractice, then you just negotiate a settlement. But of course, there are things that can happen short of that. And it does seem as if hospitals that truly implement this into their program might provide a means whereby doctor or nurses' complaints would be dealt with much more openly and honestly. So, and I don't think I don't think everybody knows that this exists. MedStar did implement the program in its hospital system. I think the Harvard hospitals implemented it too recently, some more successfully than others.
So this is a perfect example where there sounds like to be a great, resource and initiative out there, and it's just connecting the dots, and getting it to rolled out. It's coming from MedStar, but I'm no spokesperson for GW, and maybe GW's aware of it, but certainly I haven't heard of it at GW.
I'm not sure. Maybe it's something, Julia, we could do a program about for them through the medical society.
It sounds great to me. Anything that has, transparency and works towards patient safety sounds like a winner.
Right. I think it is.
Well, we're getting close to our time here. Pia, do you want to some concluding remarks?
Sure, I will. And sorry, I just had to hop off to get a call, but I did want to thank everyone for joining, and I'm going to do a quick screen share to go over some of the programs that we're doing, and also to let you know how you can connect with the Medical Society. As we mentioned, we have a physician health program in effect for doctors who are distressed and in trouble. And here is Steve Carreras' contact information. That's the best. Can everyone see that, first of all?
Yes.
Okay, good. This is the best way to get in touch with our physician health program liaison, Dr. Steve Caress. You can also find that information on our website. And then we are going to be doing more webinars in the coming weeks. Next week, same time, same place, we will be diving deep into health information exchange, which has of course become very important, and the connectivity that already exists in the District of Columbia, as well as other services and opportunities you may have not known about. And then Wednesday, May 13th, we are going to have a webinar with Council Member Mary Che. So mark that date. We haven't narrowed down the topics yet, but I think it'll probably be she'll have a lot to share with us. We have other webinars coming up, and I'm going to be sending out a survey. If you could please fill that out and let us know your thoughts, we'd sincerely appreciate it.
Okay.
And with that, I think we're done. Thank you.
Great, thanks.
Thank you.
Thank you. See you
Dr.
later.
Samenow, you did a great job
Yes,
leading
you
the
did.
group.
Thank you, Pia.
Thanks.
Yes, thank you.
Well, thank you. It was fun, and I'm always open to any, emails. Here, I'll send my email to the group
Please.
right now so that everyone has it. And if you want to talk more about any topic, or I can be of any help, just, contact me. But that's my email that I just sent out.
Okay, great.
All
Thank you
right.
very much.
You all have a great evening. Stay safe and